just yeah. So that's all. Yeah, I'll be doing. Yeah.
Okay, you're
Um,
on.
Go ahead. Yeah.
Go ahead.
If so, I know I've been asked to speak about prostate cancer. Am I right? I mean, I just want to confirm that's the talk we're doing.
Yep,
Okay.
yep,
So,
yep. You're good.
I will what I plan to do is like I will for 15 minutes I will be talking about what I generally tell patients about prostate cancer. And if you think you have any questions that I did not address during that 15 minutes, feel free to ask questions at the end so that it will be easy for you. I mean, like, sometimes like you have some questions and then sometimes after I talk, you have more questions. So it would be better that way. I mean, obviously, prostate cancer is one of the top five cancers, like as a whole, and within the men, it is the second most common cancer cause of death. I mean, when we're saying like, sorry, third most common cause of death is the prostate cancer. See, the incidence of prostate cancer is high, like it's the top cancer in men, but it's not the common cause of death, like lung cancer, colon cancer are the most common cause of death in men. But the prostate cancer, even though the general feeling is like, okay, most men die with the cancer, not from the cancer, is true, it still is responsible for a lot of cancer deaths in the society. Now, what can we do about it? I mean, why we develop? So my theme of discussions is I'm not talking about new advances in the prostate cancer. I'm more talking about the public health, general health aspect of the prostate cancer. I'm happy to address any of the advances in the prostate cancer management. But to, in the beginning phase is like why we are prone to develop prostate cancer, how to detect, screen for prostate cancer, what are the best ways of treating the prostate cancer. So those are the ways like I'm gonna focus on. So for the prostate cancer wise, so because with aging, we tend to develop neoplasms, and prostate is one of the glands that is constantly stimulated by the testosterone. See, for women at age of 50, there is a menopause. The ovaries shut down, so the estrogens and progesterones, estrogens production will go down. And whereas for men, there is a constant production of testosterone from the testicles, which in turn stimulate the prostate gland. That's why as we get old, there we all have some degree of enlarged prostates, like because of this stimulation from the testosterone. Now, during this process, at some point, like some bad mutations happen, like during the cell divisions that lead to cancer. Now, in majority of the men, these cancers tend to be of low grade and low risk of metastasis. Now, how do we know whether it is a low grade or a high grade? There are two ways. One, we can detect it with a biopsy. When you have an enlarged prostate and you have an elevated PSA, you can do a biopsy to find out whether it is a high grade or a low grade cancer, or you can do a prostate MRI. If there is a strong suspicion for prostate cancer because of elevated PSA, elevated enlarged prostate, so one of the non-invasive tools to utilize right now is MRI of the prostate. Now, the MRI of the prostate will give you that susceptibility. I mean, in the sense, it can give you the risk score. It's called PIRADS, and the higher the score, the higher the likelihood of the cancer. Just like women go through mammogram, so they annual mammogram, what the mammogram does is it gives you BIRADS 2, means it's benign, don't worry about it. BIRADS 3 needs monitoring. BIRADS 4 suspicious, you need additional testing. BIRADS 5, it's definitely cancer. That's how, like, for women go through mammogram every year. Men don't have to go through prostate MRIs every year. Okay, they don't. I mean, only people whom we suspect or we are concerned about cancer, they only need to. So that's how we detect the cancer. Like in my, so you so the screening. So one of the good things about prostate cancer, we have a very easy way of screening, which is the PSA test. Okay, so PSA has a lot of history. I mean, it's been identified as a marker for prostate cancer for almost like 30, 40 years. but the guidelines changed. It's like all over during this time. Okay, what is the cutoff of the PSA we should be concerned about? And should every high PSA should be followed by a biopsy? Or what are the ways to, monitor? So those things have changed quite a bit. I mean, not only patients, it's like the doctors made like it's a like a trial and error. Okay, oh, we made these guidelines and oh, what happened? No, this is not wrong. This is wrong. We have more cancers now. Let's change the guidelines. So because the balance acting is, if you have a lower threshold, you end up doing a lot more prostate biopsies, a lot more prostate MRIs, additional subjecting patients to additional tests, additional stress, and additional healthcare costs. If you underdose, I mean, means like if you raise the threshold of the PSA, okay, hey, like instead of 4, I will do 6 cutoff for the biopsy. Then you are missing out some of the prostate cancers that could have been cured or detected early. So this is like the balancing act that the public health has been, fighting, like, trying to do for the past, two decades. They have been coming up with new guidelines every 3-4 years. Just to give you a historical aspect, like 5 years ago when I was finishing, like I've been in Albany for 6 years as a medical oncologist. So before that, I was in a fellowship. During the fellowship, like I had the USPTF, which is the United States Preventative Task Force, released a guideline saying like, okay, hey, you should not screen for prostate cancer. Primary care people don't screen for prostate cancer unless they have symptoms. The problem is what happened, they put like, if you look at the detailed guidelines, they say don't have symptoms. The problem is men don't come to the primary care physician saying like, okay, I'm having difficulty passing urine, I'm peeing more at nighttime, or I'm having some hesitancy or slow stream. These things most men don't discuss with the primary care until it's too late. I mean, it's like, okay, hey, I really can't pee. So that's the problem. So they missed that point. Okay, hey, men don't communicate everything with the primary care, and the primary cares don't have time to listen to all the complaints. They probably have like 3 more other complaints with blood pressure or high sugars or something to discuss. So what happened is, because of that, a lot of people stopped using the PSA. Before, men age above 50 gets once a year PSA check. Okay, that's used to be the guidelines. Then like they suddenly stopped it. And when they stopped it, like there are men like, and then COVID happened. Like, I mean, at the same time COVID happened. So the communications gap has worsened, and we are seeing like a increased number of prostate cancers diagnosis, especially later stages. Means like we're talking about cancers that are more advanced than we would have otherwise expected to see before. And so suddenly they changed the guidelines again. Okay, saying like, no, we are revoking those guidelines of not doing the PSA. Go back to the original guidelines, which is like you screen man every year with a PSA test. So the question is like, let's say you go to a doctor and your PSA comes back as 5. Okay, is it high? Yes, but does it mean that you have cancer? No, it means like the odds of you having a cancer with a high PSA between like 4 and 10 is roughly around 1 in 4. Means like, there is a 25% chance that there is a cancer, between 4 and 10. That will become lower. I mean, like, let's say, what's the chances of cancer with a PSA of 2? It's never zero. It's never zero. It's probably like maybe like 2%. But you won't do a biopsy for a 2% risk of cancer. So that's why we used a cutoff, like a cutoff of 4%, like which is like 1 in 4 may have cancer at that time. Now, how do we know whether they truly have cancer or not? In general, there are other contributory causes of high PSA, like for example, they may have a BPH, like just enlarged prostate, benign prostatic hyperplasia can be responsible for it, or maybe a catheter. Like even if I place a Foley catheter, sorry.
I think that was just background.
Background. Okay. Yeah, okay, sure. Okay, no problem. Yeah. Even if I put a Foley catheter in, that will raise the PSA because like you are irritating the prostate gland while you are traversing through it. So any recent procedures, even a urinary tract infection, like where they are like, streamings like that can change the thing. So Obviously you want to make sure that the PSA is really high PSA, not like some kind of a fluke. So you do a second test, like you within a month or within 6 weeks, you tend to do um, a PSA test. And if that continues to be high, then obviously your primary care has to refer you to a urologist who can, do the next steps, like which is like, okay, whether to decide about a biopsy or a prostate MRI. There are some insurance issues here. Some insurance companies will not worry about it. I mean, they say like, okay, there is concern for prostate cancer. The urologist ordered a prostate MRI. They will authorize it. Some people say, why are you ordering prostate MRI? You don't have any cancer. Like there are some problems here, like we have to work it out. But again, most of the insurance companies are now allowing for the prostate MRIs, which can help uh, decide which lesion to biopsy. That's the advantage. Okay, so before we used to do blindly biopsy all the prostate gland, like 12 biopsies. Now you don't need it. I mean, if the prostate MRI says the cancer is on the left side, here is the concerning lesion, you just do a biopsy, just 1 or 2 cores, that's it. Okay, so that means that number of like the risk of infection, pain, bleeding all go down. Okay, so that's the advantage of having a prostate MRI. So that is the usual process. That's number one. So how to detect it and why we are seeing increased risk of prostate cancers. That's because of the history. That's the context I wanted to give it to you. Now, the other thing is, what are the other risk factors? Like, I told you age and constant exposure to testosterone is partly responsible. Is excessive testosterone supplements responsible for prostate cancer? We don't have any overwhelming evidence. Like for women, if they have postmenopausal hormone supplement therapy, it has been shown to increase the risk of breast cancer. For men, we don't have that strong association for testosterone supplements and elevated risk of prostate cancer. We don't. But having a testosterone supplements have been shown to rise PSA. They're more likely to develop BPH and more likely to rise PSA. So, but at a population level, we don't see a strong association yet with the testosterone supplements and the prostate cancer. Obesity has been the main risk factor, and consumption of high meat products, red meat. I mean, so the association of consumption of red meat and development of prostate cancer and obesity is been strongly linked. You can study the other populations, like for example, the risk of prostate cancer in South Asian men has been historically low, very very low, like compared to the age to age correlation, like because the consumption of red meat is usually low in that area, in that region. So that is one of the things, and then there is also a genetic component to it, which I will be discussing now. So the two risk factors like are more like for development of prostate cancers, obesity, I told you about, consumption of the red meat, and the third thing is African American race. So black population are at more risk of developing prostate cancer with the same, like let's say the PSA is 4 for a white guy and a PSA 4 for a black guy. The black guy has more odds of having a prostate cancer than a white guy. So that's and that is historically proven. And that is it associated with bad outcomes for black men? Yes, means black men are more likely to die from prostate cancer than a white man. Stage to stage, it doesn't matter, like stage 1, stage 2, stage 3, stage 4. Now, why that happens, there are two theories. One is like black men have more aggressive type of prostate cancer by biology, like, so the biological theory is there. But then that is being trying to refute. So there are groups that say, if they did a study at veterans of hospital. So VA hospital, the good thing is you get the same care whether you're a white guy, black guy, or a Hispanic. So it's care is the same, right? I mean, they say because it's all part of the same network. So when they looked at the VA hospital, there is not much difference between the black and white mortality. So they think it is basically because of the access to the healthcare is well, how should I put it, like is not so good for the black population. That's why they get diagnosed late, they get diagnosed, they don't get the most appropriate treatment, which could be some of the prostate cancers are aggressively managed, means you not only have to do surgery, you have to do radiation, you have to do hormone therapy, or sometimes if you do radiation alone, you have to do extended duration of hormone therapy. But these proper treatments are may not be available to them in the community setting compared to the VA setting. So that's why there is difference in, what that's why we're seeing the differences. So that's another thing that I wanted to talk about. And so the other common thing about everything is, okay, hey, I have prostate cancer now, should I go for surgery or should I go for radiation? Okay, so those are the other things that, like, commonly that bothers people, like, in the sense, like, I get second opinion visits even though I don't treat early stage prostate cancers. Usually they go to a urologist or a radiation oncologist, but I still, they want my opinion. That's where, like, you have to look into several factors, like, in the sense, like, I generally tell people, like, okay, head on head, I mean, if you really really want to know which is better and which is good, if you look at cancer free survival, means like, my goal is like, I want to live longer cancer free, doesn't matter about the consequences. Okay, so my cancer free survival is the my priority, surgery is better. You want to go with a smaller increase in risk of cancer coming back or persistent cancer, but associated with the quality of life. And I say, what is the quality of life are we missing? See, with surgery, depending upon where you get the surgery, like, are you getting at a high volume experienced surgeon versus a low volume, less experienced surgeon, the risk of incontinence, means like urinary leakage issues post surgery, is anywhere between 10 to 20%. Okay, so it means like one or two patients who undergo prostate cancer surgery will be incontinent, means they have to either wear a type like pull-ups or a Foley catheter, indwelling catheter for the rest of their lives. So that is number one. The second issue is like sexual dysfunction. During the prostate surgery, if the cancer is involving the seminal vesicles, which are the glands that are next to the prostate, that's where the nerves, pudendal nerve goes through. If it's involved and they have to remove the cancer, then pudendal nerve gets resected. When you get the pudendal nerve resected, no sexual, there is erectile dysfunction. So because of that, that risk is even like higher, like around 20-25%. So because of those two things, if you that you have to decide. I mean, the patient has to decide. Okay, hey, what am I giving up? Like that 2 to 5% increased risk of cancer coming back versus like risk of incontinence, like 10 to 20% of incontinence and sexual dysfunction. Those have to be decided. That's number one. The second thing is, sometimes surgery may not be the right thing even if you want to go through surgery, because like the MRI of the prostate already showed that the cancer is involving the seminal vesicles or the lymph nodes or something like that. In those cases, going and doing the surgery doesn't stop you there. Means like just doing surgery is not going to get rid of the cancer. You have to do more radiation, you have to do more hormone therapy. So your quality of life is going to be even much worse, like by going through it. Yes, you are doing everything possible to take care of the cancer, but you are also subjecting your body to a lot of procedures that thereby at the end result is you are incontinent, sexual dysfunction, you still have to go through all the radiation and hormone therapy. So in those cases, what we do is like we limit the damage. We say like, hey, let's take the surgery out of the question, we'll treat it with the radiation. On a big scale of things at the population level, the outcomes are nearly equivalent between the radiation and the prostate, minor differences. But if I'm seeing a young patient like who's 60-year-old, who have like good continence and don't have much of bladder dysfunction problems, surgery, I mean, you go for surgery. Okay, but for a patient who has a lot of bladder dysfunction problems to begin with, means like then you may undergo radiation. Now the caveat is like, let's say the obstruction is significant, means like they have obstructive symptoms significantly, going through surgery may be quick fix means like you're removing the obstruction, which is the prostate. So so there are, so that those are, that's the thing, like we have to discuss about the urologist and radiation oncologist. So so whenever you have a prostate cancer, you know about the prostate cancer diagnosis, meeting all the three people, like let's say you go to a Dana-Farber or a Sloan Memorial Sloan Kettering with a prostate cancer, they will make you meet radiation oncologist, surgeon, and medical oncologist all in the same day. Okay, so you get like what you call multidisciplinary team, which is what we would like everybody to get here too. Like means you have a cancer diagnosis, get evaluated by a multidisciplinary team so that they can come up with an appropriate plan, rather than just going sticking to like, okay, I just want this. I mean, that may not be a right thing. Like you need to hear the opinions of the surgeons, radiation doctors, and the oncologists to get a like a opinion. The other thing I wanted to talk to you about is, like I told you, right, lot of cancers are low grade, means most men die with the cancer, not from the cancer. So that is why there is a growing movement. Like in the past 5 years, lot of patients end up getting diagnosed with prostate cancer, means they get a prostate biopsy or they have an MRI of the prostate that identifies a suspicious lesion, but they don't undergo any treatments. They don't undergo surgery. They don't undergo radiation. Why? Because they are considered to have a very low risk disease. So in general, we take into consideration three things. Okay. Number one, PSA. Okay, is this PSA 3, 4, 5, 10, 20? Okay, so the higher the PSA, the likelihood of metastasis is high. So we won't do active surveillance for a patient who have a PSA of 20. Okay, no. The second thing is the Gleason score. So Gleason score is something that the prostate biopsy identifies, where they will tell, okay, is it low grade cancer or a high grade cancer? So if it is low grade cancer, low risk of metastasis. And then the third thing is, what's the patient's life expectancy? Okay, are we expecting this patient to be alive at 5 years? Are we expecting this patient to be alive at 10 years? Are we expecting this patient to be alive at 20 years? So if you have a very low risk prostate cancer and a patient's life expectancy is 20 years, you can do safely active surveillance. Means you will be monitoring their PSA at least twice a year. You will do an MRI of the prostate maybe once a year. And a biopsy if things change. Okay, so you don't get biopsies every year. You just do a biopsy if you think like the things are changing, the PSA is going up, or the MRI showing that new lesion is popping up, or the grading is changing. And then intervene if there is a worsening of the prostate. That's called active surveillance. Let's say a patient comes in with a Gleason score of 7, which is in the in between, or 8, but their life expectancy is less than 5 years, means they have like a lot of end stage heart problems or kidney problems or liver problems. It's still better for them to not undergo any intervention, because like the likelihood of this intermediate risk cancer becoming metastatic and take their life or affect their life expectancy is very low. So why subject them through surgery or radiation when this is not going to change their trajectory? So that is also the key aspect of it that we need to take into account. So it's one of the reasons why I have like few 90-year-old prostate cancer patients where I don't try to treat them, because like in the sense like I try to minimize, because the treatments are sometimes more bad than the actual cancer itself. So you have to make the judgment call saying that, okay, how which is affecting their life quality of life more. So and is it going to really change their life expectancy? So those things have to be considered. And let's say, like we talked about active surveillance, we talked about PSA, MR of the prostate. Yes. So
About a
the
minute
another
left.
thing, I'm sorry.
We have about a minute left.
Okay, like I'll finish like last. Okay, so see, for women with breast cancers and ovarian cancers, the genetic testing has been very like it's been educated by in the society knows that okay, there is a strong BRCA1, BRCA2, these genes are predisposed women to develop breast cancers. There is a huge health education or community education about genetic testing for women who have breast cancer diagnosis. Same thing applies to the men. See, prostate cancer, about 10 to 20% of the prostate cancers are hereditary, means like they have a genetic component to it. You inherit a mutation from your one of your parents that predispose you to develop prostate cancer. Common ones are the BRCA2 mutation. If you are harboring that mutation, your kids and next generation has to get tested so that they will be screened for it appropriately. If it is men, they are increased risk of prostate cancer. If it is women, they are increased risk of ovarian cancer. Not only that, the BRCA2 can also predispose to pancreatic cancer, bladder cancer. So that, I mean, although it's not as common as prostate and ovarian cancers. So every it's recommended that if not everybody or most of them should undergo genetic testing. Means like it's germline, means it's not like in the mutation analysis of the prostate, we're talking about the germline genetic testing. So that is also another thing I wanted to mention. Now
Well,
I'm
thank
happy
you,
to take
doctor. Any
questions. Yeah.
questions for the doctor?
Yeah, I have, I have a question because I enjoyed this immensely. I'm glad I'm doing this at Zoom. I think if I was in a restaurant, I wouldn't be able to hear you very well. Here, I got my headphones, I understand you clearly. I have prostate cancer,
Mhm.
and I found out about maybe 13 or 14 years ago, and seeds were put in,
Mhm.
and they're there. I guess they're working. I don't know. I'm having other issues with cancer now, but not prostate cancer. So I was great. You guys do a great job. You made my quality of life much better. I know that. I appreciate it very much. Although everyone else thinks other people, I don't care about them, but I'm happy with me.
Well, my own father died in 2018 of prostate cancer.
2018.
Yeah, yeah. Yeah, just a couple of years ago. Dr. McKenzie, you had a question.
Could you comment on fractionation of the PSA, that is to say the free versus the total?
Yeah, so I don't use that tool often in my clinical practice because by the time patient comes to me, they already have a prostate cancer diagnosis. But this is a tool that is used by urologists. Like, so let's say, I mean, I don't want like a primary care to take this responsibility. I would say it's better to a urologist handle this testing, interpretation of it. So PSA, when I order just a PSA, it's a total PSA, means when they take the blood, right? They develop blood and then they centrifuge it, they collect the serum, and within the serum, they test for the total PSA they can detect. That includes both the protein-bound PSA and free PSA. There is a plasma protein, unprotein, not the PSA that is not bound to the protein. So the free PSA separates the protein-bound PSA and just detects the plasma-free PSA, the protein-free PSA. So it's called free PSA. So the total PSA, and then there is a free PSA that is not bound to any proteins. Now the ratio is the key. I mean, like when you do the test, like total PSA, free PSA, they also give you the ratio of free PSA versus total PSA. Now, the guidelines, I mean, again, this is the guidelines, this is the interpretation. So sometimes like you have to bend the guidelines because of the clinical situation. So that's why it's important that the urologist handle this. Is if the free PSA percentage is high, means it's like 25, 30, 40%, the likelihood of cancer is low. Okay, whereas if the free PSA percentage is low, the likelihood of cancer goes up. Again, probably not a one test. You should not believe in just one test. You always have to repeat it, like in a 6 weeks or 8 weeks time period or 3 months. You have to repeat it to make sure that this is not like a fluke. Okay, so that's the key, and it is used again sometimes, like we use this when we don't have other tools, like for example MRI of the prostate. So that's when it was more frequently used. Nowadays the utility has gone down, means like most of the times, like we're not waiting. If you have a PSA of 8 and you repeat it and it's still 8, doesn't matter what the free PSA percentage is, you still end up getting an MRI of the prostate. You understand, like this was developed a long time ago when the utility of MRI was not well known or well developed. So nowadays, like we are moving towards imaging tools more upfront than waiting.
Thank you.
Why do you think that, I feel that the Breast Cancer Awareness Month is very well advertised and educated, and I think that's awesome. But I'm
Yeah.
very annoyed that
Uh-huh.
Prostate Cancer Awareness Month and prostate cancer is not. Why do you think that is?
We're not that brave.
Very wide variation in over time.
No, only thing I'm gonna say is this, like, as a medical oncologist, being a man, so I think I can comment on this. Let's say I tell a woman like who comes across me and then says, okay, hey, this is the risk of breast cancer. It's 10% coming back, okay? And this is the chemo that you have to take for 3 months or like even like 6 months to decrease that risk to like 5%. Most women take it, okay? Take it. They will take that risk, okay? So they will take that, okay, I want to decrease my odds. For men, it's opposite. You tell them 50% and bring it down to 25%, they will still think about it. It's just I don't know, like the thing is like, the quality of life may be more important for men than women. I mean, again, I never in their boots, right? I mean, I never in that situation, like I'm still relatively young to comment on that. But this is something, a general observation I had like for a long time. So that is why it's very hard to convince a prostate cancer patient to be even on hormone treatment or on any additional therapy, because it does affect their quality of life. Same thing attributes to the education wise. I mean, see, things are improving. See, obviously it just takes time. The whole American Cancer Society, the whole cancer movement and all those things is founded upon breast cancer. So the breast cancer, the woman who like made the movements and everything is responsible for the establishment of Cancer Society and all that. All the trials like adjuvant, neoadjuvant chemotherapy trials started there for solid tumors. But I think it's gonna get better. Like Prostate Cancer Foundation is there. I mean, mostly resources. Like how much resources are allocated for prostate cancer. I mean, are there like men fighting for it to have it? Not really. So that's the problem. Yeah.
Thank you, doctor.
Men
Thank
are
you.
just wimps.
Men are women.
Want to use it.
I think they're deniers. They try and.
Thank you, everyone. We're running late, so we got to close. Remember, gang, as we go through our week, let's try to keep in mind in everything we think, say, and do. Is it the truth? Is it fair to all concerned? Goodwill and better friendships will be beneficial to all concerned. Thank you, everyone. Thank you.
Thank you, Dr.
Thank you,
Ravilla.
doctor.
Thank you.
Appreciate it very much.
Very good.
Does anyone want to take any tickets?